So I'm going to go sort of briefly through how remote care management, which is really a mix of chronic care management and remote patient monitoring, can be helpful here. I will say out front, for heart failure, if you look at the studies that have done so far, the biggest thing, if you have to just do one of these, this is not necessarily the economic incentive on my side, but if you have to do one, care management, chronic care management is the most effective single thing you could add to your practice for heart failure patients. Touch points with the patient, calling them, talking about diet and exercise, salt intake, can they afford their medication? Can they get to the pharmacy? All that sort of stuff that's not necessarily clinical, but clinical adjacent, super important, right? We have tons of anecdotes. We do care management in-house. We also have software, but we do it some in-house for clinic customers. And we have tons of anecdotes about patients like they couldn't open the cap and they didn't know what to do. And we called and it was one quick trip to the pharmacy or to someone to drop off a easy arthritis cap opener, right? Things like that. Not something that a clinician necessarily would scope out, but something that avoids a readmission, or excuse me, not a readmission, an admission, right, for heart failure. That said, remote patient monitoring is also very, very useful. So care management gets you 75% of the way there. The last 25% is using vital data on top of that care management to track their weight, right, and look for decompensation and for fluid retention. And then remember, one of those requirements, those measurement requirements, was blood pressure. So one really good way to make sure that you're tracking and controlling blood pressure for the one's measure support is remote patient monitoring, right? Remote physiologic monitoring, which is sending out a device or handing a device to a patient and having them take measurements and then have a system or an outsourcing group that takes those measurements and watches for indicia of the patient getting worse or having issues with their care plan or their medication compliance and adherence, all that stuff, right? Again, the idea is to identify these things before a patient is in a ambulance heading to the ER, so they can go to an urgent care or make a visit with your clinic or whatever that might be. Or if it's really early, titrate the medication or change things over the phone, right, and get a triage up to the clinician. So we have a few things on the right-hand side. We have a couple studies that show the reduction in hospital admissions with these. Both of these are RPM and CCM sort of being done together. One calls it like telenursing, but it's just CCM. But the idea is that when done together and done well, these things can be very, very useful to reduce admissions and cost. The question then becomes, and a lot of groups that we have that are heart failure groups, they do CCM RPM, but they don't bill for it. And we're always a little confused by that, but it's kind of somewhat understandable. But then the question sort of becomes, do you bill for it? Because you can, right? And it's relatively well reimbursed when done at scale, which this is kind of forcing you to do. So now there is this underlying thing where, I guess, first off, CCM RPM is not required for the ASM. That said, it's kind of heavily implied because you're being graded on a curve, and these are the things, this sort of intercommunication with the patient and coordination is one of the biggest things that can reduce, right, the admissions and the cost of these episodes. So with that, then the question is, do you structure your remote care program as a fee-for-service billing program, or do you just hit the most high acute patients for a shorter period of time and try to keep them out of the hospital? As you might imagine, given that we're an RPM CCM company, but I also honestly, sincerely believe that a great way to do this is to have a more overarching comprehensive program. Bill for it, fee for service, right? You get the benefit of it for the ambulatory specialty model. And at the same time, you get some fee for service revenue, which lets you do two things. One, you could continue care on post that period. You can enroll patients earlier so that before they're considered a heart failure episode, You're already going, for their hypertension reduction, things like that, lowering risk in general, right? Instead of just the highest acuity patients, you can hit your medium and high acuity patients and do more of a population level program. And then you can bill for it. And it's relatively well reimbursed, like I said, where you get it between usually about $115 to $200 per patient per month when you're utilizing these services. One caveat is that billing anything fee for service, it's important to remember, adds to your heart failure episode cost. So let's say you are billing during that 6-month period $400 for RPM or $500 for RPM. Medicare counts that towards the cost of care for that patient. It doesn't take, though, many $20,000 admissions reduced before you overcome the few $100, right, for RPM. But it does mean that if you're not doing a good job with RPM CCM and billing for it, it actually hurts you. If it's it has to be a pretty bad faith program, I think, for that to be the case. Generally, you're even if you did 1 or 2 every 6 months avoided, you're probably paying for your entire patient panel, the differential. And generally, it's more than that. Alternatively, and this really quickly, there's a side thing here where there's an anti-kickback and beneficiary inducement thing where you can't give devices to your patients for free. They are letting that be, they're doing a $1,000 carve out. So if you want to do RPM, normally you can't give your patient a device and do RPM without billing for it. Well, Medicare, the magnanimous, folks they are like, if you want to buy your patient an RPM device, we're going to let you without billing for it. And that's part of this carve out that you can have for the patient, which is another alternative, right? If you want to just have a group of devices, hand them out to patients and use it for a shorter period of time to try to lower just the highest risk period, you can do that and not have to worry about not billing for it for a fee-for-service Part B beneficiary.